insurance industry Trojan horses in single payer proposals. And as a preliminary thing, I want to discuss the significance of the concept of risk or insurance risk or financial risk, because I think it's fundamental to understanding why this is such a serious issue. Risk, basically risk is who covers the variability in healthcare costs from year to year. Some years you'll have a pandemic, some years you won't, some years you'll have several patients with extremely expensive conditions, such as a premature infant that's going to need lifelong care due to multiple birth defects, or someone with who needs a bone marrow transplant. You get several of those in one year and you'll have higher costs. So the cost of care is sort of a jagged sawtooth graph from year to year that goes up and down. And the entity that has insurance risk is the one that has the money and is responsible for paying providers of care and covering those ups and downs. If a state were to, or a country were to retain insurance risk, they would have a somewhat variable healthcare budget, but they would end up paying the average of those ups and downs. If the state contracts with an insurance company and says, okay, we'll give you a fixed amount of money and you've got to cover the cost of care, that insurance company is going to charge you the top end of those ups and downs. So there's always a premium that you pay to contract risk out to some third-party middleman, some other entity besides the state or the government, which is collecting the money for healthcare. So every time you shift risk to some sub-entity, you're going to pay a premium for doing so because they're going to make sure they charge you enough where they're not going to lose money. But that's the problem of insurance risk. I had a friend who was an architect and project manager, and we were talking about this issue of risk in healthcare. And he said, risk, you want to avoid risk as much as you possibly can because you will always pay through the nose to give somebody else risk. So his idea is in construction, you want to nail every detail down so there's nothing left that's uncertain. And that way you can hold costs down because you're not having to pay a premium for your contractor to take on a lot of risk. So this is really essential to understand in healthcare because there's been a fad over the last, at least since the 80s, of, because healthcare costs have been rising faster than inflation in this country, they came up, policy people, the insurance industry came up with this idea of, up to now, the insurance companies have had the risk. Government contracts with insurance companies and they take on the risk, or businesses contract with insurance companies and they take on the risk. How about we push risk onto doctors and hospitals so they have the incentive to restrict care instead of us? And this idea was behind the HMO movement in the 80s, and it's behind the ACO movement now, and it's embedded in a lot of the features of the Affordable Care Act. It's pushing risk onto providers of care. So if you pay an organized group of doctors and hospitals a fixed amount of money per person, and then hold them accountable for covering all of the healthcare needs of that population. That's what shifting risk onto providers of care means. And this is called an HMO or an ACO, Accountable Care Organization. The difference is that an accountable care organization, members are assigned by where they go for care most often, rather than being signing up for an HMO like you do with a regular HMO. If you're going to be in Kaiser, you sign up for Kaiser and you know your care is restricted to Kaiser, whereas with an ACO, if you see one primary care doctor 4 times in a year and another primary care doctor once, you'll get auto assigned to the first one and he'll get your monthly payment for your care. But once you transfer risk onto providers of care, then they have an incentive to restrict care because the less care that's delivered for their population, the more of the money they get to keep. They also have a very strong incentive to cherry pick and lemon drop their patient population. Because the big problem with risk in healthcare is that way too much of it is predictable because of pre-existing conditions, demographics, social determinants of health. So if you already know who's going to be high risk and who's going to be low risk, and you want to make money off capitation, you start cherry picking your population. You only take on easy, patients who are rich enough to afford their copays for their drugs, and you don't take on sick people, poor people, people with complex problems who are likely to cost more. So lemon dropping means getting rid of high-risk patients, and cherry picking is holding on to low-risk patients. And since too much of the risk is predictable, when you have competing risk-bearing entities like insurance companies or ACOs or HMOs, the way you beat the competition is by getting a healthier risk pool than they have and dumping the sick people onto the competition. And that's what drives that's what determines success or financial success or failure with a competitive insurance situation. And we have been relying on the competitive insurance business model ever since World War II to fund healthcare in this country. And so we've had pervasive problems with denial of care and excessive administrative costs. And the Affordable Care Act and implementing accountable care organizations has just given this a new form that works exactly the same way. You get the money up front, you're responsible for covering the care, and you either make money by delivering less care, or you lose money by delivering too much care, or referring people to expensive other doctors who deliver too much care. So the idea is to push the financial incentive onto providers of care. Now, no one has actually demonstrated that this saves money. It does result in some reduction in utilization of care. But when you shift insurance risk onto doctors and hospitals, they will say, obviously, but that's not fair, because if we take on sicker people, we're going to get punished. So why should we take on sick people? And isn't that the whole purpose of health insurance? So the supposed answer to this is risk adjustment, where those that are administrating the ACO try to get as much information about the patient as they can. They're all their diagnoses codes, and the more diagnoses codes, the better. And then they use that to calculate an expected cost of care for that person per month or per year. And if you take on a sicker patient, they're supposed to adjust the payment up to account for that. And if you take on a healthy patient, they're supposed to adjust it down. Now, the problem is predicting cost of care is too complicated to do accurately. So they use crude measures that capture maybe 10, 12% of the variability in cost and use that to risk adjust. But of course, that leaves 80, 90% of the cost of care still being caused by factors that are not being captured in the risk adjustment formula. And so everyone still has an incentive to cherry pick and lemon drop. And if you try to make risk adjustment more accurate, you need to gather more detailed data, and that adds administrative costs and administrative burdens. And we're already at a point where those are excessive. So, and if we have excessive administrative burdens at 12%, and you're trying to get to 16%, and you end up doubling those burdens, you're in a situation of diminishing returns, and you cannot make it work. You cannot get to a point where risk adjustment is fair or actually effectively adjusts risk, and you're still left with incentive to skimp on care and cherry pick and lemon drop. And this has been blatantly what's happened with the Medicare Advantage program, which is supposedly risk adjusted. But despite that, the Medicare Advantage plans have all gotten very good at capturing a healthier than average risk pool in order to make money and pushing sick people back onto regular Medicare. And they do this with marketing. They do it by restricting formularies for expensive conditions, by prior authorizations, basically hassling people with serious expensive illnesses to drop out of their plan and go back to regular Medicare. And there's pervasive evidence that this happens a lot. So when we're coming to propose single payer bills, and I'm going to start with Bernie Sanders' bill, S1129, which tries to control costs by using HMOs and ACOs. So you now have multiple risk-bearing organizations involved, and they are in competition with each other. And you have the same incentives to deny care and cherry pick and lemon drop. And you have the excessive administrative costs of the model. There's no cost savings in that. You're just perpetuating all the flaws of the current model. And it's been very difficult to persuade Bernie Sanders to drop this feature from his bill, because he's being influenced by, companies such as Kaiser that are risk-bearing entities, and they say, well, we have a huge market share in California and Washington and Oregon and Hawaii, and we're expanding into other states, and you can't just dump our patients, you have to include us, so allow us to use our HMO or ACO model as a cost-saving measure, which is what its rationale is supposed to be, never mind the fact that it's never actually achieved that goal. So the result is that of this kind of lobbying and of the fact that there's a policy fad that supports risk shifting, we're getting single payer bills that have ACO and HMO loopholes in them. And that sabotages the cost savings of the bill. The other thing about this is that there's extensive evidence that the most cost-effective way to pay hospitals is with global operating budgets. And this is the HR 676, the PNHP bill, and the current Jayapal bill, HR, what is the number?
1976.
What? 1976, yes. Those do have no ACOs or HMOs, and they do have global budgeting of hospitals. If you globally budget a hospital, you're paying the hospital what you think it will cost them to run their operation, but you're not paying them per member. And you're not locking them into, this is your budget. If you deliver less care than this, you'll make money. If you deliver more care than this, you'll lose money. If you budget a hospital, you say, this is what we think it costs to run your operations, but we're not expecting you to take risk. If something happens like a pandemic and your costs change, we can go back and renegotiate your budget. You are expected to generally try to live within a budget, but if circumstances change, it can be renegotiated. And you don't have a situation where the hospital makes or loses money depending on how much care they deliver. Their job is they're being paid to do a job, and they try to do it the best they can. And if something unexpected comes up, they can come back and ask for it to be adjusted. If you pay hospitals with a global operating budget, and not a capitation budget per member, but a global operating budget to give them what it costs to do what they need to do, then you're not shifting risk onto them. If you do budget a hospital like that, what you do is you eliminate billing and collections because they're already paid for everything they need to do upfront as a budget. And billing and collections are roughly 15% of a hospital's total budget. And so that takes 15% or almost 15% because there might be some billing and collections for out-of-state people, out-of-country people who come through, but it's going to be a far smaller operation than what hospitals spend now. So you're going to take 13, 14% of the hospital's budget right off the top by paying for hospital care with global budgets. There's a question of how is the global cost determined? It would be determined initially by taking the hospital's current cost for hiring the doctors who are hospital employed, hiring the nurses, hiring the physical therapists, hiring the housekeepers, hiring the security people, everyone who's needed to run a hospital. And this cost of supplies, the cost of real estate, all those things, you add it all up and say, okay, we'll give you this budget. It doesn't include most of your billing and collections, but includes all the things that we know you need to run your hospital. And then you adjust it as you go along. So that would be how you would determine it based on past experience and eliminating the things that are unnecessary with global budgeting. So that is the way to pay hospitals if you want a cost-effective system. But if you're going to pay for hospital care as part of your capitated payments to an HMO or an ACO, you've eliminated the option of paying the hospital global operating budget. So you can't do both. You have to make up your mind. Are you going to pay the hospital the budget, or are you going to pay an ACO or an HMO to cover hospital care and try to restrict it because they have a financial incentive to deliver less care? So we feel that any single payer bill at the state or federal level ought to specifically exclude competing risk-bearing entities, ACOs and HMOs, and integrated delivery systems, and specifically authorize global operating budgets for individual hospitals. Now, so the question is, what happens with Kaiser? So Kaiser has three parts. It has a hospital, it has a doctor group, and it has an insurance function. And the insurance function collects premiums, calculates insurance risk, does underwriting, all of that kind of thing, and makes sure that the operation makes money from charging enough in premiums to make sure they don't lose from the ups and downs of healthcare. So what Jayapal's bill does is it preserves the hospital and doctor parts of Kaiser by saying if a group of doctors is affiliated with a hospital, a single hospital, and they want to maintain the arrangement they have under Kaiser where they get paid through the hospital's budget and they pay their doctors with salaries instead of independent doctors who have no employer and must be paid with fee for service or some other arrangement. So they say, okay, the doctor group can affiliate with the hospital, will give you a global operating budget that's enough for both the hospital operations and to pay the doctors, and you can pay the doctors with salaries, and you can have your doctor hospital integrated system. But we're going to budget each individual hospital separately, and we're not going to give you money to establish a chain of hospitals, and we're not going to give you money for insurance functions because you don't need insurance functions if you're being paid an adequate operating budget by the single payer. And by eliminating the insurance functions, you save quite a bit of money for the system. And this means that for Kaiser, the doctors are kept whole, the hospital is kept whole, but Kaiser corporate gets booted out. And the opposition to this is all coming from Kaiser corporate. It's not coming from the doctors in the hospital. Unless Kaiser corporate is saying, you can't talk about it, we're going to speak for you. And then they make it appear as if they're speaking for the hospital, but really this arrangement would not hurt the hospital or the doctors. You also have the purchasers of insurance, which is the unions and the businesses and the individuals who buy into Kaiser, who are happy with the care that they're getting. And they need to be reassured that your doctors in your hospitals are not going to change. You can continue to see the same doctors. You can continue to be treated in the same hospital. The only difference is we're not going to pay the overhead of the corporate chain, and we're not going to pay for the insurance functions, which you don't need because the cost is being covered. And you don't have to worry about surprise bills with out-of-network because there's no longer members. If a Kaiser hospital doctor group is paid by a single payer, they're not being paid by premiums. They're being paid a global budget. So there is no such thing as members. And anyone can go to Kaiser and to another hospital or back and forth without it being a problem because they're not locked into a closed system the way a current Kaiser is. So it would make Kaiser open. It would reduce its administrative costs, but it would preserve the physician and hospital parts of it. So this is a solution that's written into Jayapal's HR 1976. And it's what we think every state level single payer bill should also do is specify this solution to Kaiser instead of trying to appease Kaiser corporate and leaving in HMO and ACO loopholes. So that's the nutshell version, and I would like to open it up to questions, comments, discussion, whatever anyone would like.